Okay, so we'll continue here. See, Robert, why don't we start with you? What do you think of this case?
So we got two coronals. It says pain after acute trauma. Looks like there's edema of the tibial plateau with probable fracture.
Okay. Uh, so I'll give you that. That's fine. What do you think about the meniscus?
Uh, yeah, I was gonna say that
Meniscus.
looks looks abnormal, but I'd have to follow it to.
Okay, good. That's great. So let's follow it. What do you think of it now?
That looks fine.
So what's going on
um, can you get like a meniscal contusion?
here? Okay, good. So this is a low field study from a long time ago, but you see a lot of increased signal intensity here. This certainly could be a tear. You've got a fracture here, so tear. But if you follow it over time, you can see that now it looks normal. The bone is healed, and this you can contusion the menisci and get increased signal intensity within the meniscus due to contusion. So just be aware of that being a pitfall sometimes. Taysom.
Right, 40-year-old female with knee trauma.
So,
So,
we got a little signal there in the meniscus.
yeah,
What's going on there?
looks like some intermediate signal. So some intersubstance degeneration.
Okay, here's a sagittal image.
Um,
So
There's
what's this
something in
thing
the
there?
notch, but I don't know
Okay,
exactly.
so that's a displaced anterior cruciate ligament that was
Okay.
torn and inferiorly displaced. Look at now this is okay, this is on 9/21/2010.
Okay.
Okay, now we're looking at this is on 7/12/2011. What's happened here?
Looks like there's like ACL reconstruction, right?
Okay, so they put in a graft. ACR graft. This is an interference screw. What do you think about the meniscus?
Meniscus, the intersubstance signal has resolved.
Right. So this is another case of meniscal contusion.
Right.
So, and your differential is what can produce kind of diffuse increased signal intensity within the meniscus. Remember, you can get increased signal intensity from meniscal contusions. And let me just go a little further now that we know that most ill-defined signal, even if it's a tear, is a degenerative type tear. It makes you realize that those patients probably are not arthroscopic candidates. And so in your reports, you can describe it appropriately.
Um, Sagittal views, we see in the center kind of this wavy appearance of the meniscus. I think that's a flounce.
Okay, so he's waving at you.
Yeah.
And you notice there's a little bit of distension of the joint space here, so that the meniscus is really not under pressure at this point. So it's just folding on itself. So that's really a normal finding. Good. Okay, Robert?
All right, so we got a coronal and two sagittals. Looks like there's some edema in the posterior medial-femoral condyle. Now it looks like there's an ossification. Yeah, maybe up there. The femoral condyle, sorry. Yeah, gotcha. Looking at the meniscus posteriorly, it looks like there's a calcification there. Is that like a ossicle?
Okay, good. So this is a meniscal ossicle. So how do you get a meniscal ossicle? Yeah, for a long time we thought these were congenital, but the problem is you look for them in kids and you don't see them. John, were you going to say something?
No, I wanted to go back to the flounce.
Okay.
One of the reasons you see that is you can predict that that joint is kind of loose.
Okay.
Otherwise, you wouldn't see that buckle.
Good.
A firm joint will not give you that kind of an appearance. So I would probably guess that this is a female,
I don't
and
know.
and the joint is quite loose. Now, I don't know whether I ever mentioned uh, individuals with the joints being stiff and loose. I call them stiffers and loosers and everything in between. Um, and it's important for the orthopedic surgeon to mention this, I think, because the stiffers you don't want to immobilize very long because they'll get stiff. And the loosers you want to immobilize longer, otherwise they're going to get loose. So that's my comment
Okay,
for this condition here.
good.
This is a looser, so if you immobilize it, you'd want to immobilize it longer.
Okay.
So
And
I don't think that you can immobilize everybody according to what the book tells you.
thanks, John. And John will be fine tuning that concept when we go to other areas where that's important as well. Okay. Okay. So Robert. So okay. Uh, we thought for a long time these were congenital, but now most of the data, including from this article from AJR, really believe that these are due to tears. Or either partial tears or complete tears. They're usually at the root, and ossification and the healing process of the tear. So we'll see over and over again in ligaments and tendons where you can develop ossicles that are, and I'll show examples actually where you have partial tears that go on over years to develop ossicles. So we know clearly now with MR that these develop. They're very rarely seen except for a few locations congenitally. So most of these ossifications and kind of soft tissues are acquired and probably due to trauma.
All right, we have frontal and lateral radiographs of the knee with an ossicle in the posterior joint space. It could be a loose body or that meniscal ossicle we were just speaking
It
of.
could be either one, but it's right in the area of the posterior horn of the lateral meniscus.
Yeah.
You see there. And again, this is what the meniscal ossicles look like on plain film. Nice and corticated, nicely defined, in a characteristic location where the posterior horn should be positioned.
Okay.
Okay.
43-year-old male with knee pain. So we have radiographs. I see ossification kind of in the distribution of the medial meniscus.
Okay, so here's the X-ray. Here's the MR.
Yeah, some ossifications in the medial meniscus, the posterior horn.
Yeah, it's a little kind of hard to see here. You got a little bit of increased signal intensity, right?
Yeah.
And you got sagittal images. It's really kind of hard to see it on the.
Mhm.
So with standard MR imaging, meniscal ossification is actually pretty difficult to see and is usually missed. There are, as I showed earlier, but we can talk about if we decide to do the physics sections, there are techniques with MR which are actually much more sensitive than CT for detecting soft tissue calcifications, but we don't use those techniques with standard knee imaging. So sometimes the inhomogeneous signal that you might see in a meniscus, which we call intersubstance degenerative disease, that's also what meniscal ossification looks like. So if there are plain films and you see that, it's good to compare it just to see, because this is so obvious on a plain film, and sometimes you look kind of foolish if you don't talk about it on the MR scan. But if you don't have an X-ray, you can't be very specific without it. But just remember that. Okay. Meniscal ossification, the same thing as with cartilage ossification with chondrocalcinosis, which we'll talk about too. Okay. Robert?
All right. This is a rule out meniscal tear. We have two sagittals of the medial compartment. Looks like there's increased signal in that posterior horn. And then there's another.
Here's the patella up here.
What compartment are we looking at?
Thought we were in the medial compartment, but
Okay, the patella.
And how do you determine that?
I was going by the shape of the tibia, but I guess we can be central.
Do you play golf?
I do, yeah. It looks like a
Well,
T.
it looks like a T that you put a ball on.
Mm-hmm.
And so you shouldn't ever forget that. The lateral side looks like a cane. So the medial is a golf tee, the lateral is a cane.
Good job. Great. So what do you
So
think?
you don't forget how to determine what you're looking at.
Well, I think we'd be looking for a meniscal tear. And it looks like.
Since we're talking about meniscal tear,
I guess I'd have to see if it fat saturates out, but it's either an ossicle or maybe a cyst.
yeah, this is a PD image. You can see the foot is a little bit right. So it's not a T2, it says PD and T2. Kind of an old-fashioned technique.
Hmm.
Yeah, so it's kind of an old-fashioned technique, PD and T2. So this could, but this is actually going to end up being fat. If we do an oblique image through this area, we can see it there. And this is another meniscal ossicle. This is in the anterior horn. They're almost always in the posterior horn, then the body, but occasionally they can be in the anterior horn. Okay. Okay, so this is a kid that came in, I don't know, I think he was 3 years old, who had knee pain.
Okay, so
Might have been 4.
looks like we're in the looks like medial compartment, right?
Okay,
There is some increased signal within the posterior horn.
okay. So you're going to call this a tear and have him go to surgery?
Um,
How would you
No.
describe that? How would you
Because-
describe that?
How would I describe this? I would
Yes.
say there's a increased intrasubstance signal without a high signal tear.
Horizontal signal.
Okay,
I would put in the word horizontal.
good. And the reason for that, this is a pretty common normal pediatric meniscus, and that is in the first few years of life, the menisci are still vascularized, much more so than just the peripheral vascularization. They're vascularized pretty much close to the tip, whereas in adults, the vascularity only involves the peripheral third, as we talked about before, the red zone. But with this vascularity, before it subsides, you can get more diffuse increased signal intensity within a pediatric meniscus. So you shouldn't overcall these as being tears. Good.
Okay. 48-year-old woman, right knee pain for a month. Sagittal PD on the left. Meniscus looks okay. Middle is a T2. See a joint effusion. Yeah. So these T2 images,
Yeah, these are
Yeah.
the PD fat set images.
okay. We looking at the lateral meniscus? Maybe there's, is there some, yeah.
Some thing right here.
Huh.
What's unusual about it?
Well, there's this extra kind of linear dark signal that seems separate from the meniscus.
Okay, good. So is this-
Well, the meniscus looks like it goes from front to back.
Yeah.
Okay.
Maybe there's a tear and a flap, like
Okay.
extruding.
So here's what it looked like arthroscopically. So here's the meniscus. Here's the normal meniscus. And there's this black fibrous structure above it. But the meniscus looks pretty normal, a nice normal free edge. they resected this fibrous band, and this is a variant, which is an abnormal fibrous band next to the meniscus. It was thought, the posterior horn of the meniscus, this was thought to be causing mechanical effects. So they removed it, but the meniscus itself is still intact. So this is a congenital variant, abnormal band. And there's a number of these. They're quite uncommon, but just remember you can get these variants where you can get these fibrous bands next to the posterior horn of the meniscus.
And that's awfully rare.
Yeah. But you guys are going to see a lot of MRs of the knees in your lifetime, so you're going to be seeing some of these rare things. And typically, the more common things we look at are discoid variants, which we've already talked about, wrist variant, and then the ring meniscus. And then this is a less common variant where you have that extra fibrous band.
All right. So we have a sagittal PD and a fluid-sensitive fat set coronal of the knee. Looking at the lateral compartment on sagittal, I don't know if I see much, maybe some prominent meniscal tissue. So maybe it's some sort of discoid. Yeah.
Okay, so what we're seeing here is that on multiple cuts through the knee, we see that the meniscus goes all the way through the knee, including through the weight-bearing areas. On the coronal, you can see that the meniscus, the free edge of the body, goes all the way into the notch of the knee here. So this is what's called a slab top or a total discoid meniscus. There's no tear in this particular one. This can still cause some symptoms. It's a congenital lesion. Um, and these particular patients. And it's important to mention this because it can produce mechanical symptoms and and occasionally pain symptoms. It's important for the treating physician to know that there's a congenital variant there that kind of help explain things. Okay, John, do you want to comment anything on a discoid meniscus before we go and talk about other things?
Well, I used to see them in infants, and every time they flex their knees, there would be a loud pop, and a child would cry, and sometimes they couldn't walk. It would fall, and there would be effusions and so on. And you can usually diagnose these clinically, and these are not something that is caused by trauma. This is trauma may aggravate them, but you usually see these in infants and treat them as infants. So when you see them as adults, it's pretty unusual, I think, nowadays. What the
Pretty common,
treatment?
John.
The treatment for this is saucerization. What you do is you go in the center of the meniscus and then kind of make a plate out of it, so it's equal all around the meniscus. So there are no edges that are poking into the articular surface. The overall results are not that great in this condition. It goes from 45 degrees, decent results to 90, but I am a little leery about that 90 because in our series at USC we didn't get 90, not even close.
Yeah. And when we do see these in adults, which we do fairly commonly because we see so many knees here, these can be asymptomatic, and you have to remember that because what you do, you look at the meniscus. If it's not torn, you look for other areas of causes of symptoms. because if it's asymptomatic discoid meniscus, it may not require surgical treatment. But if that's the cause of the symptoms, then that needs to be addressed.
Right, if there's no catching and there's enough room in the joint, and the patient is probably a looser, you
Loser.
may not get away. You may get away with it till your third year or so. But the only one that a discoid meniscus that I saw in an adult was a female, and it was on the medial side.
Yeah,
Medial side is quite unusual.
right.
And she had a cyst in the middle of the meniscus, and I just debrided it, and she did very well.
So, Elior, what do you think of this case?
So here we see I think again, the lateral meniscus extends too far anteriorly, or I mean medially, and it might be,
Right here?
that's the lateral. Okay, I was looking at the other side, maybe medial.
Okay. So this is actually an abnormally large medial meniscus. So as John was just talking about, this is a discoid variant medial meniscus. Doesn't go all the way across, so I just like to call these discoid variants medial meniscus. And as John said, these are uncommon, but they do occur. Okay.
So we have a 5-year-old with knee pain and limited range of motion. Looking at the menisci, laterally there's some horizontal increased signal, and it looks like it's a discoid meniscus as well.
Okay. So there's the T1, here's the PD fat sat, here's a sagittal T2, also coronal PD fat sat. Right. And so this is a discoid lateral meniscus, and this has an interstitial tear. Now, what commonly occurs with the discoid menisci is that they're traumatized because you have meniscus right in the weight-bearing area, and the meniscus is really not designed to handle the direct weight bearing. It's just on the periphery, usually in the central primary part of the weight bearing, and we'll talk more about the biomechanics of this and somewhere else in one of these talks. You have direct force through a contact between articular cartilage and articular cartilage. Around the periphery, you stabilize this and you increase the contact area by having the meniscus fill in the space so that the overall contact surface is much enlarged by over 50%, but with the meniscus. But in the central part, you normally don't have meniscus. When you do, it produces abnormal trauma on that meniscus, which usually initially starts as an interstitial tear like we see here, and then it will eventually complete itself. So often with these discoid menisci, what you'll see, you'll end up with a very large macerated horizontal cleavage degenerative type tear in the meniscus, which sometimes can make saucerization a little bit difficult. But this is an interstitial tear before it's actually completed to the surface. If symptomatic, this is one you still may want to operate on to try to convert the lateral meniscus into a more normal shape. Okay.
All right, 13-year-old with knee pain.
Okay.
So,
Actually, let me take this one. So this is just another case where we have an interstitial tear. May go to the surface, but in this case it didn't. And you can see there's probably a little perimeniscal cyst here. So this is another of those interstitial type tears that you can see in discoid and discoid variant tears. Eventually, I think that almost all of these will become tears that go all the way through to the surface. Okay, here you go.
all right. 28-year-old female with pain for 4 weeks when walking. We have a sagittal PD of the lateral compartment. I guess there shouldn't be tissue there, right? At this
What?
weight bearing, or no?
Okay, so but we do see something
Yeah, we
here.
have some intermediate oblique signal reaching the inferior surface.
And here's what the coronal images look like.
Looks like a root tear. Yeah.
Well, this is a tear that involves the root, involves the posterior horn, involves the body, actually involves the anterior horn, and through the body we can see that it's a discoid meniscus. And this is that interstitial tear, but this is completed to be a complete tear. It goes all the way to the surface. So this is the next stage, and this is a typical tear that you see in a torn discoid meniscus.
Okay.
And you see the age, it's 28.
Yep.
And that's about the time when they start to deteriorate.
Okay. Ilior.
So here we have another discoid meniscus with a horizontal tear with a parameniscal cyst.
Right. And most of these with a parameniscal cyst are going to have a complete somewhere. So almost all these tears are true tears rather than just intrasubstance. And you can see that this a little bit of the signal here actually goes along Risberg's ligament as well, posteriorly here. Okay, Robert?
All right, so we got a sagittal and coronal of the knee. There's a little bit, I guess, vertically oriented signal in that posterior horn of the meniscus. I was looking at the other one, but yeah.
Okay. So what would you call this?
I mean, I would just call it a peripheral tear of the meniscus.
Yeah, I would put it in a discoid bearing or a discoid level meniscus, and maybe there's an interstitial tear here. This is what 7/18/08. Now this is what it looks like on 7/30/09, 6/30/09. So about a year later, this is what it looks
So looks like there's been a tear that the body of the meniscus, and is that a fragment in the intercondylar notch on the coronal?
like.
Yeah, and then the anterior horn looks pretty beat up there.
So this is really an interstitial tear. This is a bucket handle type tear, a tear within the meniscus. And what happens is a portion of the meniscus displaced medially, but the bulk of the meniscus is displaced adjacent to the anterior horn. So that's a big displaced tear.
All right, 6-year-old female knee pain after a fall. So it looks like we have a discoid, actually, yeah, medial meniscus.
Medial's here.
Oh, lateral meniscus. Okay.
Okay. And here's what the posterior coronal images look like.
So we have a radial tear.
Okay, so we have a big tear here in the posterior horn, and this is what the sagittal looks like.
Yeah, it looks like the whole posterior horn's missing from this slide.
Well, it's torn and it's displaced anteriorly, so it's a big displaced tear. And this is kind of a Risberg variant, but that's okay. So, okay.
"12-year-old male, no injury, knee gives way, sagittal images of the lateral compartment. The meniscus looks okay.
Okay. There are more images.
I'm looking at the anterior horn. Does look irregular. Maybe there's some increased signal there. Maybe there's a tear.
So, okay. So it looks like there's meniscus is going into the notch of the knee here, right?
Yeah. Yeah, another
The
discoid.
coronal images. There's the anterior horn, anterior meniscal tibial attachment.
Mm-hmm.
Cut well posteriorly. We see the body coming in here, but we see this continued structure here going more posteriorly.
Mm-hmm.
And then if we follow this, we have structure here. That's really, and that goes all the way back to the posterior horn.
Yeah.
So what is this?
Maybe a ringed meniscus.
Okay, and it's nice and smooth. If we look here, the peripheral margin, this looks nice and sharp. If it were a bucket handle tear, you'd have a vertical tear here, you'd have truncation,
Mm-hmm.
and this component would be displaced into a notch.
Mm-hmm.
If you look at the component in the notch, it's nice and dark with a nice smooth edge here. And right, this is a congenital ring meniscus. Good. And you've got to think about bucket handle tear or a central discoid tear. But in this particular case, the margins were all nice and sharp, and everything was nice and black, and this was a congenital ring meniscus, which is still abnormal, so it can produce some mechanical symptoms sometimes.
You just increased the ring surgically.
Okay, so we have a 32-year-old female with pain and swelling after trauma. We have a coronal and sagittal of the knee. Guess we're looking at the lateral meniscus. The anterior root looks like it's lifted up a little bit, but that might just be positioning. Yeah.
Floating meniscus, which is usually just due to when you position the patient in the scanner, you distract the knee a little bit, and so you pull the bones apart, and you get this what's called a floating meniscus. So just so you're familiar with the term, it's normal.
I don't see any paddles.
It's one of John's loosers. What, John?
I don't see any paddles.
No, see any paddles, right? Well, it's just sitting there. It's not paddling.
All right, so we got some small field of view images of the medial compartment of the knee. Looks like there's some vertical signal of posterior horn posteriorly. And then don't really see it on that.
Yeah, I'm full. I can forget this. This was actually someone who probably had a tear before this, and this was a meniscal scar.
Okay.
When they went in arthroscopically, they had to go in for another reason and were concerned what this was, and they found that it was mature scar tissue. So it probably was torn before and then had a spontaneously healed peripherally here. But that's what scar can look like. And it's not, you don't see fluid going in it. Fluid would be much brighter.
Yeah.
So, certainly this could be a tear, but the scar tissue can also look this way, and eventually, it just shows on the T2 weighted image the scar is not nearly as bright.
This has been operated on before, hasn't it?
Yeah, the patient has an ACL graft.
Yeah.
Okay.
Okay, 45-year-old man, right knee pain for 5 months, minor abnormal gait, full range of motion, feels pain with flexion greater than 90 degrees and stretched out. Okay, we got sagittals, T2 fat sat. Just looking at the meniscus here, I think the anterior horn is extruding. Yeah, inferiorly. There's some extrusion there. I don't see is there a tear on the axials? Yeah, I don't know.
So this is a term that I don't like to use, where this is a tear the meniscus with some extrusion of the meniscal components here, and it can be painful, especially in an extension where you put pressure on this. And it's a term that some people call meniscal impingement syndrome, but I think it's just due to an anterior tear with some displaced fragment. Now, a lot of these displaced fragments, when they initially displace like this, and more commonly we see them associated with the body of the meniscus, they can be very painful. But over time, the tissues, these will sometimes they'll resorb a little bit, but usually not very much. But the pain can often get much better. I know a number of radiologists who've developed these things. It's very painful at the beginning. Most of them have decided not to have surgery to remove that fragment. And over time, they all became asymptomatic. But it's a little bit like disc extrusions in the spine, though most of those will resolve, whereas the meniscus, this is fibrous tissue, so it won't. It's not nucleus pulposus material. But the surrounding tissues probably adapt to it, stretch, and you no longer irritate the nerve fibers. So a lot of these will become less symptomatic over time. Okay. Okay, Roberto.
We have a 26-year-old.
And don't you usually see a depression in the medial condyle on these, John? Or was it that lateral condyle? I forget.
It's usually the medial side, and you can, but that's pretty uncommon. But you can.
Yeah.
That's right.
Okay, so we have a 26-year-old male with knee pain, meniscal tear. We have a sagittal and coronal. Looking at the lateral meniscus, I don't see much of a posterior horn. It looks like maybe there's a flip fragment anteriorly.
Good. And you can see there's not much in the body. And patients had prior arthroscopic surgery. You see the scar tissue there. And if you go in and look at this, this is that flipped meniscus. And it's a pretty large size. In this particular case, what they did is they actually resected the flip well, actually, I think they repaired this one. Let me just see it. But I think they brought this back to repair it, but I believe, yeah. And then what they did here is put some clot in with it to try to improve the healing process in this particular case. And there you can see the meniscal sutures suturing back in place. And that was on 7/6. Okay. And then this is what it looked like after. And then, yeah, I thought this was. So they brought it back and repaired it, but to try to help stabilize it, they put in clot and they put in a collagen meniscal implant, which I haven't seen in recent years. So I think these may not have worked out very well, but they worked for a while. And basically, it really looks like a pretty normal lateral meniscus after they repaired it. John?
No, these don't work.
Okay. And then here's just some information about collagen meniscal implants. They can put them in to help improve the defect in a meniscus. Okay, and that brings us into a little discussion about meniscal transplants. So in evaluating meniscal transplants, there are about 6 things that we want to include. So you guys will see a lot of these coming from Dr. Stone this year. You want to look for if there's any peripheral displacement of the implant, the size of the implant, and initially we typically do MR scan the day after the implant to look at make sure it's positioned properly. A few we've taken back to surgery to improve it, and to make sure that the meniscal implant size is appropriate for the tibial size. And there are a number of different ways you can go about determining what's the appropriate meniscal size by looking at plain films, but we like to just confirm that in the day 1 MR scan. Then I like to look at signal intensity to look for degeneration or tears of the transplant. And then if there are a lot of tears, you can get fragmentation. You look for articular cartilage changes and progressive degenerative disease, and then bony changes. So those are the kind of the 6 things that you look for. So going through this, looking for peripheral displacement. With transplants, we like to look at them in both coronal and sagittal planes. In the coronal planes, you're looking for displacement of the body. And Dr. Stone just sent me a paper yesterday showing that if the displacement is less than 3 millimeters, the risk for developing progressive degenerative disease in the next 5 years is pretty minimal. So under 3 millimeters, they say is tolerable. Greater than that, there is data to show that subluxation is, by several papers, a significant factor in progression of degenerative disease in normal people. However, the papers for meniscal transplants have not been definitive to prove that. So there's still some debate as to the importance of extrusion of the body of meniscal transplants. So we believe that extrusion is not good, because if you have an extruded meniscal transplant, then the transplant's obviously not functioning as a transplant, so why do the surgery to begin with? But 3 millimeters is now a cutoff some people have. We also like to look in the sagittal plane right after placement, because we'll talk about placement in a minute, and sometimes placing it properly can be a little bit difficult. Now, there are a lot of different techniques for doing meniscal transplantation. On the medial side, there's a technique where you can do tunnels. In fact, often with this particular technique, people like to get a graft where the bone is still attached here, because bone heals very well to bone, but soft tissue doesn't. So you like to get a graft with little bones here, and then you can stabilize that by putting in tunnels here and tying it, or putting buttons on the other side here to hold it in place to allow the bone to heal if you have bone, which can heal pretty rapidly, or the soft tissue to heal the bone, which is a little bit more iffy. And then you can stabilize it around the periphery. Dr. Stone also likes to add another tunnel and basically at the posterior junction of the body and posterior horn to help stabilize that, to further stabilize the meniscus. And I think a lot of people are starting to use that technique that he's popularized. Now, you can do that fine. Now, on the lateral side, it's hard to do that because these kind of placements will start interfering with the ACL attachment. So, I'm sorry. This is on the lateral side. There is space over here on the lateral side where you can actually put in a bar here, which you can't do on the medial side, because if you try to put a bar on the medial side, you would impact the ACL insertion point. So on the lateral side, what people like to do is, not everybody does this, but you can, is actually take a graft where you have the lateral meniscus from the donor. You include the bone, in fact, a long shaft of bone, which can then be put in a groove in the recipient's bone, and therefore get better stabilization of the graft on the lateral side. Again, you can't do this medially, because then you would disrupt the insertion of the ACL. And then suture laterally, and then you'll find in the ones that we're going to be reading, you'll also have a tunnel going back here to the junction of the posterior horn and body to help stabilize the meniscus over there. So this is the one technique where you use the bone plugs. Here you can see this is the graft from the donor. This is would be the recipient, and this cadaver. You put in holes here where you take the bone from the cadaver graft, and then you put it into the recipient's tunnel here, and then the bone can heal to the bone, and you pull these in to stabilize them by tunnels with sutures. What that looks like on MR scan, here are those tunnels that you can see going to the anterior horn and posterior horn. This is This has been around for a while, so a lot of this is filled in the interval, and you can see the lateral meniscus, anterior and posterior horns here. And here are those different tunnels. We have one going to the post, and so we usually have three, one to the posterior root attachment, one to the anterior root attachment, and one back at the junction of the posterior horn and body. And then here you can see the tunnel going up to where it attaches to the meniscus to stabilize it. Those two, the one to the posterior root and the one to the junction of the posterior horn and the body back in through here. So that's a good physiologic placement. It looks like it's in normal position. It's not extruding. And wait, if we go back here, it's in normal position anteriorly. It's not, the anterior horn's not anteriorly dislocated, which was a common problem in the early days of positioning these. The graft is good position, and it's a proper size. The donor graft is not too large, in which case it flops over the edges, or too small, in which case there's a lot of peripheral bone here. So that's good. Now, what you'll often find is that there will be another black structure here with vertical increased signal intensity. And now, in order to further stabilize the posterior horn, what a lot of people will do is when they remove the native meniscus, they'll leave, if it's firmly attached, the posterior horn of the native, the periphery of it back here, and they'll abut the graft onto that native posterior horn, which helps improve the stabilization of the posterior horn. So don't get fooled thinking that you've got a tear there, and you'll see examples of this when you read cases, because a lot of the ones now will have the residue of the posterior horn from the recipient. Okay, so here's basically pre-op, where you can see an extensive degenerative tear involving the medial meniscus in this particular patient. Here is, this is an old case from a number of years ago, post-op. Here you can see the tunnels to stabilize it. The graft, here's the anterior horn of the donor, posterior horn. This one's a little bit asymmetrical. The anterior horn's a little bit more anterior than we would like, but it's still kind of within normal limits. And the posterior horn. Okay, here's another example. In this case, the posterior horn here was a little bit more anteriorly positioned than we'd like. The anterior horn is acceptable, but a little bit too far anteriorly, which we can see there and there. They actually re-injured, he re-injured, and they brought him back and put in a new graft, which is in better position. And we've had a couple of cases where, without injuring, on day one, when we did the MR scan, Dr. Stone thought the graft wasn't properly positioned, so he went in and repositioned it. So, okay. And here's abnormal placement here. The anterior horn's not too bad, but it's a little anterior. The posterior horn is way too far anterior.
You say that tunnel is too
anterior, and the tunnel is too anterior here. So that's not good placement. And then there's a technique called a keyhole technique, where when you take the graft, when you take the bone, you actually have this flaring of the inferior part of the bone. So it slips into, like a key, into a keyhole, and this then would stabilize the bone to allow it to heal without any displacement using this particular technique. And here's a case of that on an MR examination, where you can see the bone tunnel there, where the bone is very edematous right after the putting it in. And here's the lateral meniscus allograft. Okay, and there are the posterior and anterior horn, good placement. Here we have a sagittal images. This is right along that bone tunnel with the edematous donor tunnel bone graft right in there. Here's another example that's not the keyhole technique, but still a bar. And you can see the bar is a little bit proud here. And here's a little bit proud also, where you can see the donor bone, recipient bone interface here. Okay, and this is Here's a case where this was day after surgery was 9204. We can see the meniscus is in pretty good position here, maybe a little peripheral, but we just came back 2.5 months later, and you can see there's significant extrusion of the body of that meniscus. This is before he started using that third tunnel at the junction of the posterior horn and body. And so this is probably a non-functional graft when you have this much extrusion. Okay.
And that looks like more like dislocation rather than subluxation
Okay.
on the right.
Yeah. Okay, I'm getting a little tired here. Elior, what do you think of this one?
Okay. So looking at the medial meniscus, it looks like it's not in its proper position on the stir image on the right.
And the body looks very small and deformed here.
Yeah. Not seeing the anterior horn on that sagittal view.
Okay. Okay. So decided to go and have a meniscal transplant because this was a large degenerative tear. And so this is the day after surgery. So what do you think here?
So, yeah, on the coronal view, it does look like there's some subluxation, or there might be a fragment too.
Yeah, and you have to be a little
displaced.
careful here because sometimes you get little pieces of metal artifact
Oh,
from the surgical equipment here, which can be a little bit distracting. So I'm a little concerned about the body here, but the posterior and anterior horns look like they're in pretty good shape.
mhm.
That's 11-19-9. Here we can see the different tunnels. Here's that posterior medial tunnel. This is the tunnel to the two meniscotibial attachments. Okay. The other thing to look at is the size. Okay, and so in one study we did, we'd measure the size of the body and the different horns and follow those over time, which you can see there. And when you start getting degenerative disease of the allograft, you start losing volume within the different components. So here's a meniscal allograft. One of the problems in the early days, this is a very old low field study, was that they used a lot of metal in the area to do these, and you get a lot of metal artifact, which obscured visualization. So with more modern techniques now, they use much less metal, so you get much fewer metal filings in there to produce problems. So as far as signal intensity, again, this is nice. We get some bone edema here beforehand. We can see after the surgery that the meniscus is nice and dark. And this is on 2009. The patient came back over a year later. We see extrusion, some decrease in the volume of the medial meniscus, and we can see a vertical tear here in the posterior horn. So this one did not do well. It tore and it extruded. And so this is degenerative meniscal tear in 2000 before. This is after the graft was placed. We can see some degenerative disease of the body with increased signal intensity, but the anterior and posterior horns look like they're in pretty good shape. And then you just follow the signal intensity over time. And then you can look for fragmentation, where you get tearing and fragmentation of the meniscus, as we see here. And then it's no longer functional once you get the fragmentation and displaced fragments. Okay. And then this is just progressive degenerative disease and decreased volume of the meniscus over time, which tends to occur in these menisci. Especially
If you, I'm sorry to interrupt. If you get to the age of 50, you're probably better off with a replacement, either one compartment or both compartments instead of trying this technique. But
Yeah,
I have no experience with this technology, and what I've seen is not. I would like to see the patients, but from what I've seen on the MRI, it's always bothered me a little bit.
yeah, it's very controversial to do meniscal transplantation in patients who have imaging determination of degenerative disease. These are right now the standard. These are thought to be most useful in young athletes who have complex tears that cannot be uh, surgically mended. And then it's kind of recommended. There's several papers now to show that athletes have a much better performance and longevity. If you can't repair the meniscus, then you should remove it and put in a graft. Dr. Stone does a lot of these in older patients as well to presumably decrease the rate of progression of degenerative disease, but we quite frankly don't have the data to prove that that happens, and it's much more controversial. And this just shows further degeneration and tearing of this allograft.
It's hard to get the grafts of proper size. That's one of the big problems.
Yeah. And here's a technique here where you can see the anterior horn. Now this is the graft, and this is the native periphery of the posterior horn. So that's what it looks like, and you can see where the tunnel going to stabilize the graft is more anteriorly here, but the native periphery of the posterior horn is back here. And this also makes it more complicated because obviously you need a smaller graft if you're going to have if you're going to preserve the posterior horn of the or portion of the posterior horn of the native meniscus. And then there's the anterior horn. So that's what it looks like. Posterior horn looks in pretty good shape there. And so this is 3/9/2011. This is only 3 months later, and we're already starting getting tearing of the graft and degeneration of the graft with a large displaced tear here. So that was a tear of the allograft. Okay, and then here we can see a lack of a meniscus on that lateral side. And in this case, that's because the allograft completely fractured and displaced. Here's another fractured allograft with an unstable fragment. And this is a completely displaced bucket handle tear from an allograft. Also a big tear and failure. And here's another displaced. Like we've seen in other meniscal tears, you can see the same thing in allografts. Big displaced flap tear of the allograft. So why don't we stop here and we'll continue and finish up meniscal disease next week. Okay.
Sound good.
Well, have a great weekend, everybody.
All right, thank you. You too.
You too. Thank you.
See you on Monday.
Okay, John.
Monday.
Thank you. All right.
Drive carefully.
You got it.